يلا اتفضل دكتور.
Okay. Good evening, everyone. Today, I'm going to talk about the current topics and advancements that are available for bridge fabrication. These are the titles of the topics. I tried as possible to cover them. Some of them are well established and some are still in development. First topic, the CAD/CAM technology for the same-day crown bridge fabrication. This is a historical review for the development of chairside CAD/CAM technology, as you can see. First, the CAD/CAM systems were initially developed in 1950 by Defense Arm of United States Air Force for aircraft manufacturing. And it took 3 decades until such technologies were applied in dentistry. Francis Dorit developed the first CAD/CAM device in 1983, and this device included an optical impression and milling machine that was used to fabricate the first milled restoration. After 2 years, Werner Morman, who known as the developer of the first commercial CAD/CAM system, which is CEREC system. And for those who don't know what CEREC is, CEREC stands for Chairside Economical Restoration of Aesthetic Ceramics. So in 1985, this system, the CEREC system, was used to fabricate indirect same-day ceramic dental restoration in dental office, which was revolutionary. This scheme summarizes the workflow to fabricate chairside CAD/CAM restorations. First, as you can see, start by the shade selection, then teeth preparation, soft tissue control and retraction, digital impression, followed by the anti-defecation and definition of preparation of finish line, then designing the future restoration, then material selection and nesting, try-in, and finally, if everything was good, delivery and cementation for restoration. So this is an example of chairside digital workflow. Was provided by case report conducted by Blatz and Conijo in 2018. This case report about a 25-year-old female. Her complaint was presented to the clinic with a concern about aesthetic appearance of her 2 upper incisors. And the final treatment plan included a full coverage crown on the endothecally treated upper right central and a composite resin restoration for the left incisor. Regarding the workflow, the first step, of course, was shade selection and composite restoration for the upper left central incisor. Then preparation for the upper right central incisor to receive the full coverage crown. I have a question for you regarding this workflow. In case you need to take an optical impression, do you still need a retraction cone? What do you think?
Yes, for sure, Majd.
Yes, of course.
Yes, why?
عشان اللايت يعني to
Because
be able to differentiate between the soft tissue والfinish line تبع التooth
Yeah, to
suction.
record the full sulcus depth, of course. Visualize it for the technician. So after tooth preparation, after you finish the tooth preparation, proper soft tissue control and retraction should be done, which is critical to obtain an accurate optical scan. After you take optical impression, you still need to identify and define the restoration by the computer. The computer needs to identify and define the preparation finish line. And if he wasn't able to identify this finish line, you won't go through the rest of the steps. Next step, which is creating the design for the future restoration. So in this case, the outline for the left incisor, as you can see, this small or thin black line. outline of the left incisor was determined and exact mirror image was created and placed on the prepared tooth. And it was considered the design of the future restoration for this tooth. After designing the restoration, the material selection was done and nesting inside the block. After milling the restoration, a try-in for the, in this case, of course, was a hybrid ceramic crown. After the milling of this crown, try-in for the hybrid ceramic crown was done. Of course, in terms of fit, morphology, aesthetic function, and after that, cementation was done for the final crown. And this is the end result. Regarding comparison between the chest-side CAD-CAM and the conventional fabrication, Kolmas and his colleagues in 2015 compared the chairside and laboratory CAD-CAM to the conventional method of conventional produced all ceramic crowns regarding the accuracy and aesthetics. And I mean by accuracy, the full accuracy and fit of the crown, not just the marginal fit. And they concluded that the Select system delivered the most accurate restoration regarding the closure to the original surface. Also, regarding aesthetics, the conventional wax-up restoration continued to deliver the best aesthetic results. So the authors in their study stated that all tested methods produce acceptable results, and it seemed that there is no ideal method to fabricate all ceramic restorations. Another study was conducted by Dolev, Bitterman, and his colleague, compared the marginal fit between the chairside CAD-CAM and hot press lambda-spherical crowns, and found that no significant differences between the fabrication method tested, and both methods produce margin discrepancy values of less than 120 micrometer. This is a mistake. I write it millimeter. It's micrometer, which is within the clinically acceptable range. This table was given by Marchesi and his colleague in 2021. They reviewed the currently available chairside CAD-CAM materials. As you can see, there are 8 available materials for chairside fabrication. The table also gives you their manufacturer and their indications for use. All of this material, as you can see, are indicated for veneer, inlay, onlay, overlay, and crowns. Feldspathic ceramic and Leucite reinforced ceramics are also indicated for anterior bridge. Lithium disilicate and zirconia indicated for anterior and posterior bridge, beside the veneer, inlay, onlay, overlay, and crowns. And this GMA composite and PMMA indicated also for bridge, but with a small extent. Now, the next topic, translucent aesthetic monolithic zirconia-based restorations for strength and aesthetics. So the best way to understand this version of zirconia, which combines the advantages of both aesthetics and mechanical properties, is by going through zirconia development. Regarding zirconia development, there was 4 generations. The first generation was the 3% deuterium stabilized zirconia, which is the conventional one. This generation had a small amounts of alumina. However, because of their lack of non-cubic phases, it has limited translucency, limited light scattering, and thus poor appearance. So it was mostly utilized as a supporting framework for the fixed linter prosthesis for posterior teeth due to its strong fracture strength and biocompatibility. In the next generation, this one has lower alumina. In 2013, zirconia was improved by reducing the alumina and further improved by sintering at high temperature to remove porosities. And because of the lower alumina, this zirconia has improved aesthetic quality, but still restricted to posterior areas. Next, the third generation. The next stage in development of zirconia was the inclusion of the transparent phases, which are the cubic phases. To understand the idea behind these cubic phases or the transparent phases, why they reduce it, increase it, these cubic phases are larger in size than the other phases, which means there will be less edges and porosities or spaces between these phases, which means light will travel less, will travel in fewer edges and porosity, which means there will be less light scattering and there will be more translucency. Also, second improvement of this zirconia was by raising the yttria content to 5%. So its application was restricted to a single tooth restoration in the anterior region and fixed partial denture prostheses up to 3 units and 1 pontic between 2 crowns in the premolar regions. The fourth generation, which is a polychromic multi-layer zirconia of uniform or hybrid composite, which is the last generation. They improved the zirconia to mimic the natural human teeth, or to mimic the shade gradient of natural human teeth, where the incisal area are most translucent and the gingival area are most chromatic and opaque. So to mimic this feature, polychromatic multi-layer zirconia of a uniform or hybrid composite was created. In this generation, they combined different generations, the previous 3 generations, they combined different generations. For example, like the 3% stabilized zirconia, the first generation, used in dentine layer for higher stability and strength, and combine it with 5% partially stabilized zirconia in enamel layer for better translucency. So the resulting structure is therefore will not only have a color gradient, but also a gradient in mechanical properties. Also, they second improvement in this generation, they manipulate the chroma by adding pigments such as ceria and iron pigments. These pigments, when they apply it to this type of zirconia, will give them a different type of chroma, such as we need more chromatic color in the cervical area and less chromatic color in the incisal area. In conclusion, the yttria amount control the translucency. The yttria concentration control the color, while pigments control the chroma. I added this slide just to explore the effects of pigment concentration on the mechanical properties. Hong and his colleagues in 2006 studied the influence of several pigments such as ceria, erbium, pigments concentration on the mechanical properties and microstructure, and found that the pigments significantly influence the flexural strength. However, these pigments only slightly influence the hardness and the fracture toughness of the final material. Next topic, the biomimetic restorations mimicking natural tooth structure. Singer and his colleagues in 2023 defined the biomimetic approach as a concept of less or no dentistry. It's a conservative and only focuses on restoring the teeth and simulating the natural dentition as much as possible. And there are 3 examples of these biomimetic restorations, such as the bioactive dental ceramics, hybrid ceramics, and the one we talked about in the previous topic, which is the polychromatic multilayer zirconia of uniform or hybrid composition. We talked about this. We're going to talk about the first two. First type of material, reactive dental ceramics. Baduri and his colleagues in 2014 succeeded to incorporate an appetite-forming ability to a commercial dental restorative ceramic material to enhance the tissue attachment. So a question for you, where do you think I can benefit from this concept, the bioactive coating? What do you think? This bioactive coating, I can benefit from it in two applications. The first application, establish gap-free adhesion to the restored dental substance. The second one, which we are familiar with, is the ceramic implant. When we use this ceramic material as an implant for implant, coating will enhance post integration and tissue bonding around ceramic implants. Hybrid ceramics are another example of biomimetic materials in which both ceramics and composite combine to make a material that has a similar mechanical properties to enamel and dentin, which are the elastic modulus and hardness. Dixon and his colleagues in 2013 evaluated the clinical performance of polymer infiltrated ceramic network and found that the material can be milled in thin layers, but still strong enough to prevent cracks which are stopped by the interpenetrating polymer within the network. Next topic, the artificial intelligence. Artificial intelligence technology has impacted the process of prosthetic restoration from treatment planning and diagnosis to fabrication process. And in this regard, we have the application, artificial intelligence in diagnosis, digital impression acquisition, and in prosthesis design and fabrication. Let's talk about the application. First application in diagnosis, Dobrin and his colleagues in 2020 used diagnostic imaging artificial intelligence, which is Sidexis 4 from Dentsply Sirona, to analyze radiographic images and other imaging data, which aid them in diagnosis and treatment planning. Such artificial intelligence technology used to detect bone loss, periapical lesions, osseous and cystic lesions, and produce detectability percentage, such as the one shown in this figure at the top right. This is a detectability percentage for example, the existence of cystic lesion, or if there is a vertical or horizontal loss, vertical or horizontal loss of the bone. Not only give you a detectability percentage, it also can measure the size of these lesions or the level of the bone and produce them as coordinates that can be transferred into Excel sheet. Second application, the digital impression acquisition. Nidelko and his colleagues in 2017 used artificial intelligence technology to facilitate the real-time assessment of the obtained digital impressions, pointing out the discrepancies and offering feedback at the same time. You have to understand, not all systems provided with such accuracy feature. This accuracy feature can alert the dentist about any discrepancies, and if there are any areas that need to be rescanned. So such mechanism mitigate errors and substantially reduce the time taken to acquire impression, enhancing the efficiency of the process of treatment planning. And the third application, which you are familiar with, CAD/CAM software such as Exocad and Smile design softwares. I think Abdullah will talk about them in details in the next seminar, the Smile design. So I will not going to talk about them today. Hybrid ceramic materials for versatile restoration. Next topic. As you know, dental ceramic has the advantage of flexural strength and the color stability, but there is also the disadvantage of wearing the antagonist teeth and the need for a minimum preparation of 1.5 to 2 millimeters. That's why the hybrid ceramics developed. The hybrid ceramics developed to take the advantages of the lower brittleness of composite material and the aesthetic properties of ceramic materials. And there are two main families for the hybrid ceramics, which are the nanoceramics and polymer infiltrated ceramic network. I'm going to talk about the main properties for each family or main type. First property of the nanoceramic, which is the nanoparticles that are added to the composite material to fill the space between larger filler particles and reduce the resin content. And these nanoparticles will cause less spaces, which means less light scattering, which means improving translucency. Also, reducing porosities. If you are incorporating nanoparticles within these spaces, you will reduce the porosities, so you will improve the compressive and tensile strength. Second property, nanoceramic material also have a similar modulus of elasticity to dentine. And the third one, secondary caries are reduced by eliminating microleakage. The second main type, which is the polymer infiltrated ceramic network. The main property for this family, or this main type, the ceramic framework, which here predominates in this block structure, is reinforced by a fully interlocking polymer network, which is the polymethyl methacrylate. Now, this polymethyl methacrylate will reduce the crack propagation that often observed in ceramics. And this in turn also will induce or enhance the fracture strength and further increase the mechanical properties. And the second property is the fabrication of the infiltrated ceramic under high pressure and temperature will result in higher volume of filler and higher conversion rates than indirect composite resins. This table summarizes the materials that are available, the currently available hybrid ceramic materials provided by Alper and Sival in 2023 in their review. You can see 5 types. 4 of them belong to the nanoceramic. You can see the Vita Enamic is the only one listed under polymer infiltrated ceramic network. You can see in this table the ceramic percentage by weight for each material. You can see also the indications for use for each material. All of them indicated for inlay only veneers. Materials such as Cerasmart and Schofoblock and Vita Enamic. These are also included for crowns and implant restorations. Next topic, the laser dentistry for precise soft tissue contouring, gum recontouring, and depigmentation procedures. Capodefero and Kazakova in 2022 suggested that dental lasers demonstrate several advantages for soft tissue dental surgery compared with the conventional surgical methods, which are the excellent coagulation, the reduced to no need of anesthesia or suturing, and the faster healing. However, the authors also mentioned that dental laser effect of gingival recession or bone tissue damage still need to be studied. Okay. This is the case series conducted by Silva and his colleagues in 2022. It's about 6 female patients, non-white, with a mean age of 23. They have gum smile, and the etiology was related to altered passive eruption. So in this case series, they conducted a split mouth case control study in which they conducted a conventional gingivectomy on the right side and a laser gingivectomy on the left side. The conventional gingivectomy was performed with 15C blade using internal bevel technique, and the laser gingivectomy conducted with high-power diode laser. And of course, the amount to be removed was marked with a biological pin, then removed in both methods, in both sides. So the right side by conventional, the blade technique, and the left side, gingivectomy was done using the laser. Silva and his colleagues also compared between these two methods, that is a conventional gingivectomy. First, they conducted a thermographic examination. And they mentioned that in their study in 2022, this is the first time the first time ever they used something like thermographic examination in dental field. So in this thermographic examination, thermographic images was made using infrared sensor. This sensor used to measure the thermal gradients in the regions of the 6 teeth where the gingivectomies were performed. So they took a frontal image for the 6th patient and observed the thermal gradient above the zenith points, as you can see here. Both sides. As you can see, the conventional surgery area, which is the red area, presented with warmer color, which means more inflammation than the yellow area. They also used the same technique to measure the temperature in both areas and compare them. However, no statistically significant differences were found between the two methods. As you can see, there is only 0.1 difference between the two techniques. And they consider it not a statistically significant difference. Regarding clinical examination, the author examined several parameters such as the keratinized gingival width, the probing depth, the clinical crown height, the anatomical crown height, and again, the authors found no significant difference regarding these parameters. Other factors, such as bleeding, there was bleeding in all conventional cases while performing the procedure with the laser. None of the cases presented with bleeding. So this is the first difference. Regarding the postoperative pain in the 3 evaluation periods, after 1 day, 2 days, and 1 week, there were no statistically significant differences. And tissue repair, regarding the tissue repair, they found statistically significant differences between the control and the tested group within 14 days after the procedure. And you will see now in conclusion, they concluded that the conventional showed better tissue repair than the laser technique. So the conclusion, the author concluded that the laser gingivectomy was more effective regarding the absence of intraoperative bleeding, while the conventional technique promoted better tissue repair. No significant differences were observed in the other parameters, possibly due to the minimal damage caused by gingivectomy. I also added this to make it more comprehensive, laser dentistry for depigmentation, same case series. Tran and his colleagues conducted a cross-sectional study to evaluate dental laser for as a method for depigmentation. This case, about 38 patients who complained of black gums and 10 maxillary teeth for each patient from 1.5 to 2.5 exhibiting moderate to severe melanin pigmentation was selected. So there is an index called the Dammit-Gupta Oral Pigmentation Index. This index was assessed preoperatively and postoperatively. This index has 4 scores. The first score is score 0, which is no clinical pigmentation, pink color gingiva. Score 1, which is slight hyperpigmentation, light brown tissue. Score 2, moderate hyperpigmentation, medium brown tissue or a blend of pink and brown. And score 3, which is severe hyperpigmentation, dark brown or green-black tissue. And as you can see in this figure, preoperatively, before the laser depigmentation, cases has a score 2 to 3. And after evaluation, after 1 week, 4 weeks, and 12 weeks, the score shifted from 2 and 3 to 0 and 1. As you can see, these 3 evaluation periods, this blue column means score 0, and this red column means score 1. And these are the clinical pictures for one of the patients. You can see this is before the laser depigmentation. According to the index, she has a score 3, dark pigmentation, as you can see, dark brown pigmentation. And after the 3 evaluation periods, 1 week, 4 weeks, and 12 weeks, you can see an improvement, almost no pigment, no brown or dark pigmentation, which is a score 1. It's not score 0 because she doesn't have a pink gingiva, still not pink gingiva. Conclusion, the author concluded that using the carbon dioxide laser was a safe and effective modality for removing melanin pigmented gingiva. Patient pain experience was reduced after 1 week of treatment, and a better healing process was shown at 7 days postoperatively. Moreover, the aesthetic outcome after the carbon dioxide treatment of pigmentation was improved. Therefore, it's clear that the efficacy of the carbon dioxide laser method is obtained, and it's recommended that clinicians consider that carbon dioxide laser method as an option for pigmented gingiva removal for their patient treatment. Okay. Next topic, the precise temperature control for improved efficiency, precision, and use of.
I'm going to stop here
Experience.
because the time limit is about to finish. And we will continue after the break, okay?
Yeah.
Inshallah. We will continue after the break. So 10 minutes break and then we'll come back. Inshallah.